We have new lipid guidelines. Now, they've come to us a bit circuitously, but we do have new guidelines. And I'm here with Chip Lavie, who is Medical Director, Cardiac Rehab and Prevention at the John Ochsner Heart and Vascular Institute. All right, we have new guidelines. Let's talk about them. What's important?
Well, I mean, these guidelines have been long coming. I mean, people have been expecting the NCP4 guidelines for the last 2 years, and they seemed like they were never coming. And the ACC, ACCF, and American Heart took over these guidelines, and at least they've finally come out. And there certainly are some good features. I think good features are allowing some relatively low-risk patients not to be treated based on the guidelines. That's probably a good thing. Certainly a good thing is increasing the emphasis on many people can benefit from statins, and statins now have so much evidence both for efficacy and safety.
I mean, that's the consumer story that has come out, is that you probably should be on a statin, is just about the way the story goes.
So many, at least moderate and high risk patients should be, and now they're generic drugs. You know, so there's less, there's not the same cost issues that there were in the past. And the efficacy is excellent, and the safety really is very, very established now. So that's a good thing. They've also given some emphasis to not just 10-year risk assessment, but giving some emphasis to longer 30-year lifetime risk assessment, which would be a good thing for younger people. Those are good, and probably given a little bit more emphasis to things like family history. The potential role for C-reactive protein for helping clinicians make decision making, including also coronary artery calcium scanning if the calcium scan is very high, above 300, or you fall into the 75th percentile or higher, with your age-adjusted coronary calcium scan, that would emphasize more treatment. I think those are all good features. The negative feature, though, is that clinicians have been very used to targets, and targets for LDL, and really many clinicians have thought that non-HDL, the data was actually stronger than for LDL because it represented all of the atherogenic lipoproteins. And now the emphasis has been taken away from shooting for a target. Now, that is somewhat good for some people, is that it adds to simplicity. But it also does, and it does, probably in some borderline cases, and I'll give you an example. If somebody has an LDL of 77 on high dose intense statin therapy, but they're not at this, people want to use getting it to not only under 100, but wanting to get it to the previous under the 70 optional goal. Well, there's very little proven data to show that getting it under 70 from 75 or 78 is going to be given clinical event reduction. So now the new guidelines give the clinician the out that they could stop there. They don't have to push it further. But they also give many clinicians the out to being much less aggressive, not just with getting the LDL from 78 to less than 70, but what if it was 95? They could, and they are on high-dose statin, 40 or 80 milligrams of a generic atorvastatin, for example, and they've gotten a 50% reduction in their previous LDL, but they're still running a 95 LDL. There's nothing to say that they have to push it further now. Now, you could say in the past, they were still not, the mandatory guideline was just under 100, and it was optional to get it under 70, but many people were really following that optional goal, and now it really gives them the out not to. And now it also gives clinicians the out to not treat triglycerides and low HDL. And one can say, well, some of the big trials have been failures, and it really depends on how you look at some of the trials. Certainly AIM High, when the LDL started at 71, they added niacin to statin therapy. The trial was stopped less than 3 years, and it didn't show any clinical event reduction. But even in that trial, there's been a couple of recent JACC papers that show that those who had the high triglycerides and low HDL looked like they were just about getting a statistically significant further event reduction. And just for example, with fenofibrate, there was a big one a couple of years ago in the New England Journal of Medicine, the Accord lipid trial, that basically the headlines was that fenofibrate was totally useless in diabetics who were on a statin. Yet, clinicians only use fenofibrate in patients with high triglycerides and low HDL, and in the group who had high triglycerides and low HDL in that trial, there was almost like a 34% event reduction with adding fenofibrate to simvastatin.
Right.
And so I think the current guidelines actually probably lessen the need to more aggressively treat the LDL as well as non-HDL values. And I think many clinicians are concerned that although certainly it may prevent some overtreatment, but it may actually lead to undertreatment and less aggressive treatment, and possibly a reduction in the cardiovascular risk reduction that we've been getting with the more aggressive therapy that clinicians have been using for the last several years.
What about patient monitoring? How often are the recommendations now for getting a panel done?
I don't think that they pretty much don't require you to do frequent monitoring of patients. They'll say you have to do a monitoring of one time a transaminase value. You don't have to do that over and over, and that's been pretty much in the guidelines anyway. That you don't have to you don't have to do muscle tests.
Right.
Some clinicians have been doing that. They've actually suggested, probably rightfully so, not to do that. And they've made some good suggestions that maybe people over age 75 should be more likely started on moderate doses of statins. The diabetic patients who don't have established cardiovascular disease probably should be more treated with the moderate doses of statins as opposed to the high doses. So there certainly are some good features in the guidelines. I think though that we're going to hear a lot of lipid experts probably in the next many months that some of them are going to have some serious concerns.
One of the reasons to check for cholesterol is to make sure the patient is responding and to make sure the patient is taking the medication.
Sure, and I think, honestly, I do think that most clinicians will continue to do that from the clinical practice, and actually patients will want to know. Patients will want to know what their lipids are. And so even if we're going to say, well, the guidelines say you don't need to know, the patient's going to go, well, I mean, I want to know. I want to know
Exactly.
where I am now. Have I responded to the medication? My cholesterol used to be this, and now, what is it on therapy?
I mean, you said early on clinicians are interested in this. Patients are too, really.
Absolutely. And I think that with any guideline statement, and I'll just give you an example, they don't tell clinicians you can't focus on targets. What the wording said was that the committee did not make any recommendations for or against shooting for LDL and non-HDL targets. So they didn't tell the clinician that they couldn't shoot for targets.
Right.
And so I think many clinicians will continue to do it, and so they're within the guidelines. Now, what they're allowing, though, is that based on the new guidelines, a clinician who didn't check, for targets and didn't push targets for LDL and non-HDL lower, the new guidelines are telling them they're not doing wrong either. And I do see some benefits of that, but like I said, I think there are definitely good features of the guidelines, and I think if one did follow the guidelines to a T, there is the potential for undertreatment. I have a feeling that's not going to happen, because I think that clinicians who want to be more aggressive are already going to continue to be more aggressive than what the guidelines tell them.
Now, in the past, ACC and AHA have done a pretty good job of updating things regularly. Do you think it'll be sooner rather than later when we see a new iteration of this, 2 years down the road as opposed to 10?
Yeah, I think, that's certainly, I mean, the last NCP guidelines came out in 2001. Yeah. And there have been a couple of minor updates, like a 2004, particularly an update, but really not much update since 2004. I do think there'll be a continuing new statements that will come out. I mean, certainly there's going to be statements about triglycerides, and triglycerides is one that certainly will have to be dealt with. And right now, I think people are still, treating the severe hypertriglyceridemia above 500. But in between, you got a lot of wiggle room now. Because of not having to do the non-HDL and non-HDL targets. Basically, you just have to get them on a statin, and a statin at either moderate or high dose, depending on where your risk falls. And I do think there probably will be other statements that will come out. But in a way, we do need some more data, for some things. And if we had more data, that clearly showed benefits as opposed to extrapolating, and I think it would be easier to write a clear guideline. And the problem is right now we do have a lot of conflicting data. We've had negative studies. We have negative overall studies that are negative, but then subgroups that are beneficial. But you could say, well, the subgroup was not pre-planned. This was a retrospective analysis and dissecting out a group that seems to benefit. But I do think as clinicians, we're forced to do that for many things. I mean, we don't have a definitive randomized controlled trial for many things that we do clinically. That most people really, most clinicians, and I'm not just talking about, I'm talking about really skilled clinicians really believe that this is helping patients. And I think that's the same thing with what people have been doing with lipids.
Well, we're trying to help the doctors, too, from ACC and AHA. If you go to CardioSource and actually look for the guidelines, you've got them in Jack, but online, you're going to get, if you go to the guidelines section, you're going to get a variety of other tools that will help you understand the new guidelines and, of course, read the new guidelines for yourself. For CardioSource World News, I'm Rick McGuire.